Now we're going to see the idiopathic thrombocytopenic purpura or immune thrombocytic purpura. It was called immune before when we thought it was due to a immunological response to the person self. Alright, the causes could be like a immunological, for example, a antibody, usually a IgG, against a glycoprotein of the platelet. This would be, for example, the glycoprotein 2B, 3A. This is the one in which the platelets bind and aggregate. This antibody is specific, is sensitive. The antibodies are sensitive, but are non-specific for the etiology. So the best initial test is a complete blood cell count, and we would see the decrease in platelets. And there is no most accurate test because this is a diagnosis of exclusion. The patient is presenting with the bleeding, and in the complete blood cell count, we will see that there is decrease in platelet, and the times are normal. The PTT and the PT are normal. So we know that is a problem with the platelets, and now we need to know if it is a destruction problem or a production problem. This is a destruction problem. The patient makes antibodies against the proteins, and the spleens destroy them. Actually, the antibodies are made in the spleen by plasma cells, but also the spleen is destroying the platelets when the antibody binds to the glycoprotein. So the spleen is the cause of the problem, and the originating problem, that is producing the antibodies and is removing the platelets, is destroying them. Now the diagnosis of exclusion would be any cause of thrombocytopenia. This includes, for example, the uremic hemolytic syndrome, hemolytic uremic syndrome, aspirin, or other drugs that decreases the platelets, sulfa drugs, infections, malignancies, things that decreases the platelets. Now, if we don't find anything of this, we say that the patient has idiopathic thrombocytopenic purpura, and this also could be, you can think like of some of these causes. Obviously, if the patient has the hemolytic uremic syndrome, we're not going to say that has the idiopathic thrombocytopenic purpura, but for example, if the patient has HIV, we could say that the patient that now is bleeding has idiopathic thrombocytopenic purpura. Or if the patient has the chronic lymphoblastic leukemia, in which the leukemia is due to mature cells that are lymphocytes, usually B lymphocytes, and are producing immunoglobulins that are non-functional, but also these immunoglobulins can attack the platelets, and so the patient has idiopathic thrombocytopenic purpura. Also could be seen in lymphomas and infections like HIV or hepatitis C virus, also in connective tissue diseases like lupus, systemic lupus erythematosus. Now the diagnosis, yes, it is a diagnosis of exclusion, and among the things that we're going to do to exclude the diagnosis is a ultrasound or CT scan of the abdomen in order to see the spleen, because these patients do not have splenomegaly as opposed to the purpura thrombotic thrombocytopenia or the hemolytic uremic syndrome. Sometimes certainly the purpura thrombotic thrombocytopenia has the spleen enlarged, and the idiopathic thrombocytopenic purpura doesn't. So we need to exclude this during the CT scan or the ultrasound of the abdomen, and also for the history that there would be no one of the penta that we will talk in the next video for the thrombotic thrombocytopenic purpura. Well, so it is very important to do to look that there is no enlargement of the spleen. The diagnosis is if the platelet is less than 30,000 and severe bleeding, well, mild bleeding, then the first line treatment is prednisone or some other steroid like dexamethasone, usually for 4 to 6 weeks. This is usually what it takes to elevate the platelet count to more than 50,000 per cubic millimeter. And after this, we will taper this corticosteroid. If the patient is asymptomatic, then we usually don't treat it. And if the patient has a very severe bleeding, we do transfusion of platelets, but it is very rare that we do the platelet transfusion. We only give it if there is life-threatening bleeding like GI bleeding or brain bleeding, and during the splenectomy. Now the splenectomy is going to be done if the patient does not respond to prednisone, and so the patient is steroid dependent, so there are a lot of recurrence of the bleeding events, and so the patient needs to undergo a splenectomy. Now before the splenectomy, we do bone marrow biopsy. In the bone marrow biopsy, we will see that there are increased megakaryocytes because of the destruction of the platelets, so there is turnover of megakaryocytes, and this, you could say that is the most accurate test, but is very rarely done, only if the patient has a typical presentation or is over 60 years of age, or before doing the splenectomy. The biopsy that shows increase in megakaryocyte will reveal that this is a destruction problem and not a production problem. And because the megakaryocytes are larger than platelets, and also the young platelets are larger, we will see an increase in the mean platelet volume, like mean corpuscular volume, but this is for mean platelet volume. And the mean corpuscular volume certainly would be normal. So splenectomy for recurrent episodes, this will be in the patient that is steroid dependent. And if splenectomy fails to control the episodes, then we could consider rituximab. Rituximab is a monoclonal antibody against the CD20 of the B lymphocytes. So we will stop the production of the antibodies against the platelets. We could give rituximab, azathioprine, that decreases the activity of lymphocytes, B and T lymphocytes, cyclosporine, and mycophenolate. Also, if we need to replace the platelet, we can give thrombopoietin. Thrombopoietin is the like the hormone that makes that the bone marrow produces megakaryocytes and then differentiates to megakaryocytes and then platelets. This thrombopoietin, synthetic thrombopoietin, will be a thrombopaque, or thrombopaque, or romiplastin. So we would usually give this. Now, after the splenectomy, it's very important to vaccinate the patient against Neisseria meningitis, Haemophilus influenza, and pneumococcus, because these are encapsulated organisms, and the patient that has problem with the spleen is very likely to undergo infection with these microorganisms. So we need to vaccinate the patient, and only for severe cases we will do the platelet transfusion, and sometimes we could also give IVIG. These are intravenous immunoglobulins, in order that, let's say that the macrophage of the spleen gets distracted because they are binding to these immunoglobulins instead of binding to the immunoglobulins that are attached to the glycoproteins of the platelet, and so we decrease the destruction of the platelet. We could give this, or we could give the Rogan or the anti-D antigen for patients that have blood type R positive. Also in the testing, I forgot to say, we will test sometimes for Helicobacter pylori, HIV, and HCV, and certainly the blood type of the patient.